So, good evening, everyone. Thank you for joining us on the first episode of the ACHD Hive talk. I'm Dr Melissa Bouchard, the founder of the ACHD Hive, and with Professor Ewa-Lena Bratt, we've designed a series of talks about and on ACHD. And for our first episode, we felt that transition was a very important, relevant, and collaborative topic. So for this session, I'd encourage all to keep your videos on, but to remain muted until we get to the interactive part of the session. The first part of this session will have an educational presentation delivered by Professor Moons, and then the panel of experts will facilitate discussions. And this is the part when everyone can ask questions, share their opinion, either through the chat or raise a virtual hand. So with no further ado, I'd like to introduce Professor Moons, Professor of Healthcare and Nursing Science, Editor-in-Chief of the European Journal of Cardiovascular Nursing, extensively published, expert in transition and care, and I'm very, very honoured that he agreed to present on our first episode. So over to you, Professor Moons.
Thank you so much, Melissa. Thank you for the introduction, and I'm honored to participate in this inaugural session of the ACHD Hive. I would like to share the screen. So here we go. And hopefully this is what you all can see now. Okay, here we go. Transition, a journey towards empowerment. That is exactly what transition is all about, and hopefully this will become clear during this presentation. I would like to start raising attention for two very important statements. And if you want to read up on the things that I am presenting today, these are the documents where you have to go to. But of course, I would like to take some of the highlights from these statements. First, let me start with the most boring part of this presentation. It is the definitions. We need to know what we are talking about. And the good thing is, in the position statement, or consensus statement, I should say, published in the European Heart Journal, we had a glossary of terms. And transition here is defined as a passage from one life phase, physical situation, or social role to another. Actually, transition is a very broad and very generic term, and every one of us is going through transitions. This is important to bear in mind from the beginning. Another term that is relevant and very important, and sometimes interchanged with the term transition, that's the term transfer. Transfer refers going from one place to another, and specifically in congenital heart disease, we are talking about the transfer from pediatric cardiology to adult-focused care. A third term is transitional care, and this is the provision of interventions that specifically are addressing the needs, the educational needs and the support needs of young people with a chronic condition, and to help them to develop from a dependent child towards an independent adult. Quite often, when you hear people talking about transition, we do transition, actually they mean we provide transitional care. And the final definition I would like to address here is a transition program. And a transition program is a set of coordinated transitional care interventions. So it's clear when you have different interventions and you bring them together in a comprehensive and integrated program, then you are talking about a transition program. It is also very important if you provide one intervention, let's say education, you cannot talk about a transition program. This is a transitional care interventions. So, like I said, this is the most boring part of this presentation, but an important one. A second element when you are talking about transition is what do you want to achieve? And the great thing is that over the past decade there have been two international groups that have tried to get an understanding on what should be evaluated when we are evaluating transitional care. And these groups have used the methodology of Delphi. And these groups came with a different or a wide variety of outcomes, going from quality of life, knowledge, continuity of care, ranging to more aspects that refer to access of care and continuity of care. And each of these domains can be more operationalized in terms of outcomes that can be measured. The difficult part in this, however, is that quite often these outcomes can be considered as distal outcomes. This kind of outcomes cannot be reached in 1 year, 2 years, even not in 5 years. Here we are talking about outcomes that can be reached on the longer term. And of course that is difficult for healthcare providers to wait for 10 years before you can really substantiate what your impact is. And therefore we need to look at what are the outcomes in this list of outcomes, what are the outcomes that are more proximal. Interesting enough is when you look at these different categories, there is one common denominator, and that is empowerment. Empowerment, so to speak, is an influencing factor on all these different outcomes. People who are empowered, research has shown, in general have a better quality of life. People who are empowered present with better self-management. People who are empowered know better how to navigate in the healthcare system and so on. So it is clear that if you would be able to empower your patients, and if you are able to assess, to evaluate this level of empowerment, then you have a kind of an intermediate outcome of transitional care. And from this point of view, it's no surprise that the title of this presentation was Transition, a Journey Towards Empowerment. There are different ways how you can provide transitional care. And there are several models, and in this European Heart Journal paper, we presented 4 models, but not to say that there are only 4 models, but at least these models are well known, and these models are sometimes used in clinical practice. And let's have a closer look. One model is called the joint clinic model. This is a model where, and let me show the laser pointer here. Just before the transfer, the adult congenital heart disease cardiologist is joining the outpatient visit at Paediatric Cardiology and is kind of presenting themselves and presenting what will happen once that the patients and their families have been transferred to adult care. This is actually a one shot. It's one moment, one meeting that the ACHD cardiologist is having with the patient and the family. The second is what is called the introductory model. So around the time of transfer, and this can be done just before or together with the transfer, a visit to the ACHD clinic will be made and the team will be introduced. When you hear this, you immediately reflect on the fact that when we are talking about transition and transitional care, is this really transitional care? It's clearly only introducing people. And a transition program entails more. Third model is what is called the pediatrician in adult care model. So the pediatric cardiologist, is joining the patient during the transfer and is continuing the follow-up in the early phase of adult care. But slowly the input of the pediatric cardiologist is decreasing and the input of the ACHD cardiologist is increasing. So the handover is done in a more gradual way. And then finally, you have the transition coordinator model. And here on top of the standard care that is provided by pediatric cardiologist and ACHD cardiologist, you have a transition coordinator. This is a dedicated person trained to perform transitional care interventions. And this transition coordinator will coach, will be a companion during several years before the transfer, and even will join the patient after the transfer to adult care. When you are critical and when you look at these four models, then it becomes clear that actually only this transition coordinator model is a real transition model. The others can be more considered as transfer models. And that is indeed the critique that is given to the other models, that they are not really assisting the adolescent and the families in the transition, but it's only facilitating the transfer of care. What should be done, or what could be done? And if you ask me if there is one slide that you need to remind or remember after this seminar, it's this one. Because this is exactly providing the information on what should be integrated in such a comprehensive transition program. And you have the phase of transition, but of course you need to do some preparation, and it doesn't stop when the transition is finished. There is also a post-transition phase. Here below you see the timeline, the ages of the patients. Roughly you can see that there is a need for a transfer from pediatric cardiology to adult congenital heart disease care, and here this is indicated roughly at the age of 18. You see the gradient zone here. In fact, it is not a hard cut, this 18 years. In some countries it will be the case. In other countries the transfer will be postponed a few years. In other countries or other settings, the transfer is even done at the age of 16. That depends on what is possible and what is the local structure. So transfer need to be scheduled, but all depending on the local situation and possibilities. What should be done? Well, you need to start early with introducing the transition phase, and that belongs to the pre-transition. It is indicated that you should start with this at the age of 12. And with this, we don't mean that you need to start transitional care interventions at the age of 12, but at least you need to start informing the young person, the child at that moment, or the early adolescent, and the family that there will come a time that we will start preparing you for the transfer. We will start transitional care interventions. So probably your next visit or the visit after, then we are starting to talk about transition. Be aware that this will come your way. That is called the introduction here. Then around the age of 14, you need to start to intervene. And what are the interventions? First of all, an assessment of the needs. We need to know the adolescent and what is important in the life of that adolescent. We need to start the counseling and education. You will hear later that education is a critical element of transition. It's not, education alone will not be sufficient, but it is definitely a critical element. And also around the same time, you start developing a transition plan. What will be done in the upcoming years? What are the goals that the adolescent is proposing, and how can we achieve these goals? And this is a trajectory that starts and before the transfer, and it also continues after the transfer and slowly fades out. And therefore, you see the line that is interrupted here. Other elements that are critical in the transition program is facilitating peer contact, because quite often these adolescents think that they are alone in the world with their problems. Once that they learn to know peers who are dealing with the same struggles and who may have found some solutions to handle that, to solutions to cope with certain issues, that is really very empowering for them. The introduction of the ACHD team occurs around the same period. And then, of course, we know how important continuity of care is. At this moment, we need to start monitoring the continuity of care and to make sure that the care is continued after the transfer. We should not forget the parents. So transition is it's not about kicking the parents out of the room. It is by involving them, but involving them in a way that they can prepare and they can learn about their new role as well. What do we know about the evidence to support this? Well, we can say that the work of Andrew Mackey's group in Edmonton in Canada is really groundbreaking. And these were the first studies that were done on transitional care interventions in congenital heart disease, the so-called chapter studies. In the meantime, we had the chapter 1, chapter 2, chapter 3 studies. Essential for these studies was that the transitional care that was provided was primarily focused on education of the patients, and the design that was used was cluster randomized control trials. This was really informative to see what could be done and to see that certain things are working, But of course, cluster randomized controlled trials also have their limitations. More recently, a study from Belgium, from the Ghent group, was published, where a one-group pre-test, post-test design with a non-equivalent post-test only comparison group was used. Also here, a quasi-experimental study, but also very important and informative. What do we learn from these studies? Well, the outcomes of these trials showed that transitional care can result in better transition readiness, reduced delays in accessing adult care, and improved knowledge and better transition experiences. This kind of studies, even with the limitations, but this kind of studies have prompted the American Heart Association and the American College of Cardiology to include in their latest guidelines that, and you can read it here, clinicians caring for patients with CHD should deliver developmentally appropriate transition education to adolescent and young patients with congenital heart disease and their families and support network. This recommendation received class 1 and level of evidence was B and R. And let me explain a bit more what this is. This is actually the classification system that AHA and ACC is using. And if you focus on what was the recommendation here, you could see class 1, which means it is strongly recommended to perform this intervention because the benefits really outweighs the risk. However, the level of evidence to support this recommendation was of moderate quality. Indeed, there were no randomized controlled trials where patients at an individual level were randomized to either a control group or an intervention group. And that was the reason why level B, non-randomized, was assigned to this recommendation. The European guidelines even didn't touch upon this aspect precisely because of the reason that no hard evidence was available at that moment. I'm using the past tense when I'm expressing this because things have changed in the meantime. This is the first genuine randomized controlled trial that was that was conducted and published in the transition program in congenital heart disease. It's the Stepstones transition program, and Ewa-Lena Bratt is here in this panel today, so she can address this further in the discussion later on. The primary outcome of this trial was empowerment. And remember what I said in the beginning about the outcomes. Empowerment is a kind of an overarching yet intermediate outcome. But again, if you are able to increase the empowerment in our patient, we will have an indirect impact on other, more remote, more distal outcomes. Yes, the intervention was proven to be effective because the mean change in the intervention group was larger than the mean change in the control group, resulting in an effect size of 0.4, and it was statistically significant. Regarding the secondary outcomes, there was a reduced parental involvement observed, and this is exactly what we want to achieve. We want to gradually reduce the input of parents and the independence of the young person themselves. An improved overall transition readiness, an improved satisfaction with the physical appearance, and an improved disease-related knowledge. No significant difference was found for these secondary outcomes. Very recently, a study from France was published, the Transition CHD RCT. Again, this was also an RCT where patients were assigned to the intervention group or control group at an individual level. The primary outcome in this trial was health-related quality of life total score. And yes, also this trial found a significant difference. So the mean change in the intervention group was also larger than the mean change in the control group with an effect size of 0.3. Regarding the secondary outcomes, the psychological component of health-related quality of life, the physical component of the proxy health-related quality of life, which means the assessment of the parents, and disease-related knowledge all improved. Factors that did not show an improvement were exercise capacity, level of physical activity, and mental health issues such as anxiety and depression. So, if you translate this new evidence back to the recommendation, and once again, I'm using the AHA and ACC classification, but the ESC, the European Society of Cardiology classification, is very much alike. We still can say, yes, it is recommended, strongly recommended because the benefits outweighs the risk, but now we can say the evidence is based on high quality studies of more than one randomized control trials. And these randomized control trials have confirmed the previous studies that were using quasi-experimental studies. So, let me come to the conclusion of this presentation, and it's actually very simple. Today, we know what transition is. The definitions are clear. We know what it entails, we know how we can define it. We also know why it is important. There are a lot of studies that have shown why we should invest in transitional care and transition program. The fact that this session is held here is also illustrative for the importance of transitional care. We also know what transitional care and by large transition programs, what they entail. We know exactly what should be in such a comprehensive program. The recommendations are there. They can really guide clinicians and program managers to implement it. And fourth, we now also know that it works. And it works with a lot of confidence. We can say it is recommended class 1 and it's based on high level evidence, level A. So my question to the congenital heart disease community and to everyone who is asking what should we do about transitional care, well, we know what it is, we know why it is important, we know what to do. Let's make it happening. Why are we waiting? And I think this could be a nice bridge for the discussion with the panel. Thank you so much.
Thank you so much, Professor Moon. This was a really thought-provoking presentation. I'd like to invite the panel of experts, please, to come and introduce themselves, please.
So maybe I can start. Hi everyone, my name is Ewa-Lena Bratt. I'm a professor in nursing science. I'm working at the University of Gothenburg in Sweden. And I have been involved in the Stepstones project together with Philip. So we have been working on different transitional research projects since 10 years back, I think. So these kind of projects takes quite some time, but nevertheless are really, really important, of course. And well, maybe I should just give the word to the next person in the panel before we start the discussion, I think, maybe. So I pass the word to you, Lynda.
Thank you. Yes, I'm Lynda Shaughnessy. I'm a lead nurse in Paediatric Cardiology at Guy's and St Thomas's Trust. I started working in the field of transition back in 2006, which is quite depressing when we're still asking the question of why, when to start. But yes, I'm very, very keen advocator of transition. And so I'm going to pass on now to Oktay.
Thank you. I'm Oktay Tutarel. So I'm the head of the ACHD Center here in Berlin at the German Heart Center of the Charité, and I'm the professor for adult congenital heart disease at the Charité University Medicine here in Berlin. And I've worked in transition, well, as an ACHD cardiologist since we started. We tried to implement something here in Germany. It's not so easy. So we're happy to discuss about that. And was also honored to be a small part of this fantastic paper, which Philip Moons led in the European Heart Journal. And I learned a lot during that process. I'm not sure where I should pass it now. Maybe to Melissa Magali.
Yes, I can introduce myself. I'm Magali Ladouceur. I'm an ACHD cardiologist in Geneva, as well as I'm a professor. And I'm involved in transition in a program in Geneva as well as in Lausanne. And I'm very happy and to see all these great experts on transition to maybe to start the discussion, because I don't have any question from the chat. And if you want to ask some questions to the panel, do so. Write your question in the chat. I would like to know, according to your experience, all of you, if you have identified the strongest barriers in the transition and transfer process. Maybe, Philip, you can start. According to your research, if you have identified the main barriers, maybe it's from the patients or the patient or the parents or the doctors. It's interesting to know.
Yeah. With the patients, there is absolutely no barrier at all. In a sense that for young people, for adolescents, for them it's a no-brainer that they want to move on and they want to be cared for in adult care. For the parents, it's more difficult because they trust the pediatric cardiologist so much, and now they need to learn someone else, and they are wondering, are they as competent as the pediatric cardiologist? Can we trust them as much as we do with a pediatric cardiologist, and so on? That is definitely not something that cannot be overcome with an introduction to the ACHD team and with how the process will be cared for. The problem mainly is from an organizational point of view, I think, where healthcare organizations so far did not know what to expect from transitional care, what would be the results. And as long as we did not have the hard evidence, it is difficult to convince policymakers and payers to say, well, yes, we should invest in this because we see that these are the outcomes. Once again, this is changing with the mounting evidence that is there. So that's how I see it.
I totally agree. I don't know if you have others experience about this when you perform your research. Yes, I see, Ewa-Lena, you want to say something.
Yes. So I can continue. So I could completely agree with Philip says. But I also want to add, I mean, we can add this list, it's a long list, but I can just add something that I think is important. I think it's important to also acknowledge that, to be honest, both pediatric nurses, pediatricians, if we start there, they have like lack of knowledge and education when it comes to adolescent health and adolescent medicine. It is like we are quite good in taking care of small babies and younger kids and their parents and the family-centered care. But when it comes to adolescents and young people's specific needs, we are not really that good, to be honest. And I think that's a very important barrier. We need to have like education and courses to provide courses for both physicians and nurses in adolescent health in general, because this is not only a congenital heart disease problem, it's like for all the young people with different chronic diseases. So that's one thing I want to highlight. And Lynda.
I 100% agree with that. I think that's probably one of the biggest barriers we see in our sort of staff groups, is even just how to communicate with adolescents. And I think it's something that people sort of shy away from, because you're not just communicating with the adolescent, you've also got the parents as well. So you don't want to get it wrong, because you don't want to lose especially if you're meeting them for the first time, that's your opportunity to really get them and to build up a really good rapport with them all. I think the other things that I was making a little list of my own actually, and I think one of the big issues is the time it takes to put these programs in place, but also to really take a patient. For some of the patients, it's a long journey. As Philip sort of alluded to, you can be starting this process at 12. And I know certainly in some of the programs I've worked in, we follow some of the patients up to 25. So that's a lot of intervention time. And actually, when you look at sort of hospitals and organisation and the financial positions that we often find ourselves in, it's quite a daunting thing to go and ask somebody to fund such a program when you're asking for such a huge amount of clinician and people's time. And then the other thing is just to sort of totally agree with what Philip had said as well about getting the parents on board very early on, I think is also so important. I think that often when they've been through the paediatric service for a very long time, even where you have adult services within the same hospital, parents often don't realise that those are specific adult congenital services, and they're fearful that their child is going to end up in a big pile of general cardiology, and that the clinicians won't understand what it is that their child has had. And if single ventricles, then there's even more anxiety attached to that. So I think making sure that we tell them all of those adult services early on, and that can be part of the introduction, where we're not really even doing any of the interventions, but just introducing them to the services that are available as they go through the process.
Yeah, I think it's an important point which you alluded to, Lynda. I think we all agree on how important transition programs are, but the problem, at least in Germany, is funding. So it's not part of the clinical service. We don't have anyone who's paid for that, and we don't have any funding from health insurance or whatsoever. So we're trying to implement something like that in Berlin, but we applied for a foundation. Hopefully they will fund the position for that, but it's not really part of the training. In Germany, it's more like the model which Philip beautifully showed, the transfer model, where people just say, well, you're now 18, you go over there, and then it's kind of only the transfer model. And I think funding is a huge problem, even if you want to do it and apply it, and we don't have enough funding for a lot of other things, and no one will fund you stuff like that, at least not in Germany.
I'd like to follow up on that, Oktay. Several years ago, on a conference, it was a nurse researcher who investigated a specific intervention in heart failure patient, and his final slide was, we fund drugs that are effective, why don't we fund human resources that are more effective? And to a certain extent, now with this class 1 level A evidence, there is no argument, and I mean, we are in agreement with this, but it's other people that we need to convince, of course. There is no argument why we should not fund this kind of human services, because if transition would be a drug, it would be immediately implemented and it would be reimbursed. Yeah. So the question is, why aren't we doing this? And probably healthcare system funders as well need to be more convinced that human resources, if proven to be effective, that they need funding and need to be reimbursed and so on as well.
But I think it's also easier to measure. So if you have a drug or a pill, whatever, you give it, and it's got, and if you show that, and Lynda also alluded to that, it's a long process. Transition is not like we're doing one clinic, we have one chat with them, and everything will be fine. And you can show the next time they come around, everything's perfect now. So it takes much more time, and in this short memory world we are all living in right now, it's kind of, no one has kind of the patience to fund something which needs maybe 10 years time to show the effectiveness, and this might be a problem.
Yeah, fully agree.
Melissa, you have a question.
Yeah, no, and following on from what you guys are saying, how could we actually implement that? Instead of seeing that transition person as like someone different, initially, would it be like Lynda was saying, would it be that, and Professor Bratt, would it be that we train the paediatric teams to learning and understanding adolescent medicine, and also the adult teams to learning about adolescent medicine? Because being from the other side, from the adult congenital side, sometimes when I myself get a patient that is starting to be referred at 16 and they still appear young and they come on their own because we don't have this sort of transition pathway yet established, it feels quite a shock even for myself, because I've got a patient who's quite young, who looks quite young. Sometimes basic things like still on liquid medication. I don't normally deal with liquid medication. I'm an adult cardiologist. I don't know what to do with that. And so there is that disconnect. And I would be all for being taught a little bit, sort of like, let's go a bit backwards and learn a bit about adolescent medicine, and maybe actually instead of seeing it like a addition of a job or a particular person, maybe it could actually be someone from already that team that's there. So it's just extra learning. It's just a suggestion.
Yeah, I do agree with that, and if I'm honest, when I look back at programs that I developed in the past, I would actually change the way that I've done things. In that, I guess, in the past, when I've sort of set up transition programs, they've been very specifically cardiac centered, and what I've seen now, going back where I was in adult congenital heart disease and I've gone back to pediatrics, is that actually our patients coming through have many other needs. And so they're often not only under a transition program for cardiology, they're also under one for maybe renal or neuro or other services. And so actually maybe one of the things that we can do is to look at transition programs that are holistic to the entire patient and not coming from one service, and then training both our pediatric and our adult congenital teams to be able to do some of the work with the young person, but then using whole hospital teams to be able to actually provide the transitional program. That might be another way around it, and then we're not taking all the money from one part and one service. We're actually sharing that across other services. I can see Ewa-Lena's got a hand.
No, I just want to say I completely agree, Lynda. I think if we will change this discussion from focusing on the barriers to like the facilitators, what can we do? I think that's the important thing that Lynda is what you just said now, because I think the power of like broaden this like challenge. I mean, we know that it's a challenge for all young people with different chronic diseases. So I think that's one point, as you just said, Lynda. And another thing is, I think we also have a kind of a healthcare system that is not really helping us. At least in Sweden, we had like a hard. It's when you're 18, you're supposed to go to the adult care, and to be honest, that's something that maybe we cannot do anything about that. We just need to see how can we handle it. So some certain barriers, we have to kind of choose the fight, so to speak. What can we do? What do we think that we can affect, so to speak? But another thing, Lynda, in addition to what you just said, when we talk about facilitators, we shouldn't underestimate the power of the patient and the patient's organizations. That's super duper important, because if we can gather the patients and supporting this, because that is what happens in Sweden right now, that the patient organizations really are raising their voices, and they are trying to reach decision makers and politicians. And I think we just have to try to highlight this problem together with the patient organization, because they are a very important and powerful voice. So that's what I wanted to add.
Absolutely, and then I think now we are gathered here, and everyone is kind of agreeing that we need transition, what transition should be. But at least in Germany, many doctors and organizations will think they're doing transition, but they're doing just transfer, what Philip just showed. And even in the setting in Germany, there's actually also a hard cut at 18, but it's not really lived by, because we don't have enough adult congenital cardiologists. So many pediatric cardiologists are looking with patients, but they still think that they do some kind of transition, because patients stay at the same outpatient clinics. They don't have to go anywhere else. Even if they transfer it, we have some settings where it's a department for congenital heart disease, so patients are looked after from birth till death. And they say, okay, it's transition because we don't need transition, because people stay in the same outpatient clinic, sometimes even the same doctors. And so it's kind of, I think it's also raising the awareness in the community, what really transition means, and how early it should start, how complicated it is. It's not only just a quick chat. So it's a combination of that. And then again, I think that's what you said, Eva, said the patient organization might help in the setting, that they say we have these needs, no one is addressing them, and how can we do it, and how do they do it, I don't know, in the UK, in Sweden, in Belgium, and how could we apply that in Germany? I think it's important.
I have a comment in the chat. I let Lynda answer. Talk first.
Okay, I was just going to say that actually the patient voice, as Ewa-Lena has said, is so important. But also, I think is being able to collect that patient voice together. And Philip did mention in his slide about sort of introducing the peer support element of transition, and certainly that's been one of the most powerful things in programs I've worked in, is when you do bring patients together, because they often do feel that they're on their own, and actually being in a room with other adolescents, and whether that's, we've done various different versions, but we have a large one which actually hasn't run for a little while. It's been a bit difficult to get up and running since COVID, but we had real successes with it as a pan-London event, and it was called Rhythmic Beats, and we had at the highest level 90 young people in a room together, and then sort of 90 supporting family members in another room, and that's incredibly beneficial. We've also done specific ones with learning disabilities groups. We did one recently, which we've now moved to sort of geographical areas to try and make it easier for patients to travel to. And we've just brought hospitals that are close together that we've then done joint groups. And I noticed somebody's put in the chat about youth workers. And yeah, we do have youth workers in our program, and they come along and really support those groups. Unfortunately, our youth workers are charity funded, though they're not funded directly from the hospital, which is sad but true.
I can go to the question in the chat, because there one, how do you capture the pediatric patients who are ready to transfer? Here in Kaiser, Northern California, we are trying to use EMR to help identify patients along with pediatric providers' inputs. Who wants to answer?
Maybe I can start. Thank you, Jen, for the question. Indeed, it all depends on what kind of collaboration you have between pediatric cardiology and adult congenital heart disease. In situation, and that would be the ideal world, where the two programs are communicating, are collaborating, and have a policy to transfer patients to each other. That is, for instance, something that we also recommend in the consensus document. Make sure that you have a policy document, that it is written. How do you collaborate with your referral partners or with the ACHD programs that are receiving the patients? But of course, in other centers that are completely disconnected, where pediatric care and adult care is completely disconnected, that is more problematic. That is for sure. That would be my first reaction. Ewa-Lena, you want to follow up on this?
Yeah, I can just follow up on you, Philip, because what I'm thinking about is, if you, in such a healthcare system, I think it's even more important to consider the education of the patient, to really make sure that they know and that they are aware of the importance to follow up, a lifelong follow up, but also to make sure that to empower them, to make sure that they will. I mean, I guess it's like maybe they have to find their own adult care provider when pediatrics are when they are supposed to be transferred. But in that case, I think it's even more important to really, really emphasize the importance of the education of the patients and empower the patients and the parents. As a very short comment.
Yeah, I think that's really important, is to empower the patients. I think also sometimes the language that we use in pediatrics, and when we still say things like total repair, for instance, which we're then telling patients they need lifelong follow-up, and that can be confusing. So I think, that there is some sort of education for pediatric teams in how we communicate the need for lifelong follow-up, but without, because there is this fear, certainly in teams I work in, where if we tell them all the time they're going to need lifelong follow-up, we're scaring them about the future, rather than necessarily, actually, you are well, but we want to keep you well, and that's why we want to follow you up for the future. So I think it's sort of working with teams as well around that. We've recently, in our service, put Epic as our patient records in, and we're currently trying to devise a system within that to flag up patients when they reach 12 years old and ready to start the transition process. We haven't got it there yet. Currently, if I'm honest, it's a really difficult task of paediatric nurses looking through clinic lists, and that's really the true way that we manage to pick up the patients. Very time consuming.
Yes, there was one comment in the chat about patients with learning disabilities who may find the transition process complex for them. And also I can add one of my comments about when there is no an appropriate parental environment to help the adolescents to progress up to adult age, it may be more complicated to do a good transition and a good transfer. And do you think that we have to identify these young patients to put on them more care and allow them to have a better transfer and then follow up?
Maybe I can start responding to this, Magali. When you look in the literature, it is clear that people with learning disabilities do have the same issues, the same challenges as other people, but on top of that, the learning disabilities is hindering them from getting the appropriate care and so on. So yes, learning disabilities complicates the transition process substantially. The tricky thing is that I plead guilty. Once that you are designing a study, the first group that you are excluding are people with learning disabilities. And that is why we should really invest. That is, to a certain extent, the new wave of studies that should be done. How can we adapt transitional care to this kind of people that are afflicted with learning disabilities? I would like to give the word to Ewa-Lena here, because I know that she is preparing a study in that group of patients.
Yeah, this subject is, of course, as Philip says, very, very important, and this also requires specific components in the transition programs, to be honest. And we just started to plan a new study where we are going to adapt the Stepstones project to young people with learning disabilities, and also with other diagnoses that might affect, like the cognitive. They have cognitive challenges, also with diagnosis as ADHD and so on, which we also know that quite a lot of our patients have. And they also have specific needs. Even if you take like a young person with a congenital heart disease, and then you also add cognitive challenges such as, and also an ADHD diagnosis, it is really, really challenging. And we also know that some of these patients actually are not, they have even more problems with taking over the responsibility for their health. They have like less healthcare, self-care. They have poor self-care management. That's also shown in the previous studies. So that's a true and quite a huge challenge. And we will come back and see how we will do that. What we do now is that we do take our transition program, and we are collaborating with healthcare professionals in these specialities, and we will also start to have like a co-creation design where we discuss the components together with patients with such learning disabilities and so on. And that's at least a start, but we need to address it, even though it's very, very challenging. We cannot like hide and say this is too challenging. We have to address it somehow. So we have to start somewhere. So this is a start. But hopefully we will come back and see how we end it in a couple of years.
Okay, I think we'll be closing the session now. Thank you so much for a really interesting and thought-provoking discussion. I've made loads of notes. I feel that I'm ready to try and implement a change, and it sounds like if we try and push for the power of empowerment, we'll probably get very far. But I'd like to thank Professor Moons and all the experts and Magali for all your help with this session. I hope everyone found it as interesting as I did, and we'll be posting the session on the website. And we're planning the next episode for the next month or so. So please join us. But thank you very much all for joining.